them to switch that off. Now, there are certain guidelines which have been given by the Bureau of Energy Efficiency from the Government of India, and if you try and stick to those guidelines, then you do get very good results, which I would like to show you. What we have by way of sanctioned power and what we utilize is completely different. I utilize much less than what I have sanctioned, and this can be returned back to the grid. So therefore, you also have a social responsibility. And it is possible, if we maintain good efficiencies, to actually contribute to the cause of the nation. Water conservation, well, we're the only hospital in Mumbai that has rainwater harvesting, and we have done the stormwater drains go into the underground wells. And for the monsoon seasons, that is June, July, August, and September, we do not use the municipal water for flushing. And also, we have an area of dialysis. We have a large dialysis center. We have 10 dialysis chairs. But what happens to the effluent? So we've directed the effluent also into our rainwater chambers so that we can get this chamber and we can do at least about 4.5 million liters of water just on flushing in our hospital. So these are some of the changes that we have to think through. We have to implement. It is inescapable. A time will come when this is inescapable. In addition to the above, there are some innovative measures that you need, self-closing taps, which you have a particular frequency. You can say 10 seconds and it just stops on its own. So I don't care if you have to keep on pressing the tap. It doesn't bother me, but water you waste. So there are so many complaints that I get, while I was washing my hand, the water went off. I said, why don't you press the thing again? Water will come again, and again it will go off. So be it. What's going to happen tomorrow? There are going to be retrofits. Retrofit is a nightmare. In a running hospital, retrofit is a nightmare. We've undergone retrofits. There was a bunker that we needed to construct, and we'd asked the best construction companies to come and do it. And they said, no, we're not going to do it. Some of them had even made atomic reactors. They said, no, we can't do it. So we sat together, and we have made a bunker for ourselves. So retrofit is going to be a nightmare for hospitals. When we started the retrofit, we actually called the construction team and told them what was hospital infection, and they all laughed at us. He says, you mean our workers are going to go this way? He said, yes, your workers are going to come. I don't care if they sit on tubs and they're taken up. So we will provide the lifts, we will provide everything, but your workers will not come through the hospital. It's not always possible, but sometimes it is. But retrofit is going to be a problem. Energy conservation, functional efficiency for patient safety, and aesthetics. Aesthetics, because for discerning people, ladies and gentlemen, we have a vibrant economy. People are going to be able to afford, and people are getting health conscious. So therefore, they would want good aesthetics. So therefore, retrofit, as I told you, my God, I'd rather not see this picture because I don't get good sleep when I think about this. But aesthetics, yes. So therefore, you would have good areas, some photographs from what we've created. What I've spoken about, I have delivered on site. We have a dental chair. As you can see, there's enough and more sunlight coming through. Now, the reason why we have a roller blind is during the monsoon, I don't want somebody sitting there and looking at a window and suddenly there's a blinding flash of lightning. He just runs away from our dental center. We didn't want that. Well, you have all this, and this is something that people are going to be demanding, and that's going to be another shift in paradigm as far as hospital infrastructure is concerned. Aesthetics is going to be quite important. These are spaces which people would want in healthcare, which are called like day spaces or lounges, where you can a person who is recuperating doesn't require a hospital environment. So how can you create that hospital environment? And this is going to be nothing out of the ordinary, let me tell you. So I think this is the best part of the talk. Healthcare is certainly a sunrise industry, and we are going places. Now, land and physical infrastructure are a huge capital cost which has to be reduced by, specially implemented materials, methods, innovative technology. And services costs can actually result in poor, that is, earnings before income, depreciation, taxes, and amortization, and which will keep the project's financial viability low. Therefore, for the above, if we don't have good construction technology, if we don't think out, as people say, off the box, then you will not be able to ensure business viability in hospitals. Mr. Chairpersons, ladies and gentlemen, thank you.
Thank you, sir. I must congratulate you for planning your talk very well and finishing it well within the time limit that is given to you. You have stressed on very important aspects of the construction of health infrastructure. The foremost thing what you said is absolutely right about time of completion, because most of the times the projects take a long time, and if the project is delayed, there is cost escalation. And also, what we think is the state of art at the time of planning the project will become outdated and outmoded by the time it is completed. And you also stressed about the end users' involvement in planning and designing the hospital, because most of the times when the hospital is constructed, the end users are not in the picture, and when they start using it, they will find a lot of deficiencies according to them. You very well stressed about the energy efficiency, which is absolutely needed in the present scenario. You also mentioned about water conservation, because most of the hospitals need both power and water plenty, and at the same time, we all know that there is wastage of both power as well as water in most of these healthcare infrastructure facilities. I appreciate that the point what you said, the power that is sanctioned and the power that is utilized. But we all know that we are paying for the power that is sanctioned. In spite of that, if the power that is utilized is less, obviously we are conserving a lot of energy, which is good for the community. Now I will ask my co-chairperson to give his remarks and then invite the next speaker.
Thank you, Dr. Rao. At the outset, I'd like to commend this very important initiative which the All India Institute of Medical Sciences has taken in bringing the engineers and the doctors together to really look at some of the problems which are common problems and how we can take the solutions forward. Because this is the era of interdisciplinary actions to be taken, where you need to come out of your silos and do the problem solving, which takes care of your own domains, and you also bring in the value addition from your domains into the other domains. It was a wonderful talk by Dr. Chatterjee. I'll only share with you some of the additional technologies which have become available, which will help you as designers, as engineers, as users, to really come out with the ultimate end product, which is much easier to comprehend now. You have technologies where you can resurrect through the use of GIS, three-dimensional infrastructure before you really actually implement and go through the total infrastructure in terms of functionality, bring your users, end users together, and ask them whether they like this particular design. Is it good from the retrofitting point of view? All those things are possible because you are visualizing. You are visualizing as if the structure is being built and is already available to you. So all the issues of usability, all the issues in terms of whether the sunlight will come into the room or not, how much will come, how much is the size of the window which you need to really take on board, and the cost effectiveness, every aspect can be studied before you actually implement those things. So those technologies are being used by some of the designers. They are giving you the options. They are making it look as if the building is there. You can walk through the building. You can make the patients walk. You can do all those kinds of things. That is the era where I think is a much different than just conceptualizing in your mind and then looking at later on that there were some things, few things which were left. The question of water, its utilization, is treatment and making use of the wastewater. That's very important. It's becoming more and more important on account of your increasing demand because of your population, because of your urbanization, as well as the other external factors which are on account of the climate change. That's the thing which I'm studying very closely. How the resource, the water resource, might be much lower than what you're already having as a routine within the natural variabilities which we see. What you'll do, how you'll distribute the deficit. So I think each drop is going to be more important and well saved in future. When we talk of saving, when we talk of conservation, we have to be careful that we don't use some of the options, we don't go overboard. For example, when we are talking these days of the rainwater harvesting, I think if you go too much beyond the capacity of the system to allow you to do the rainwater harvesting, it might be detrimental to the health of the river system. So if everybody is trying to stop the water where it drops, is that kind of slogan which many people are giving, is a very bad slogan, because then you will stop many of the rivers to flow. So you have to keep a balance. You have to look at where the trade-offs are. That is a caution which I think is very important to understand, because when we talk of water, we only talk of as individuals' requirement. We don't look at the other sectors, what they require, what is their legitimate demands. And those are issues, I think, where a lot of technologies are again being used. And I'll stop there. I just wanted to raise some of these issues. Now we'll go to the next second presenter, who's Susan Francis. Susan is currently Program Director for Architects for Health and Special Advisor for Health at Commission for Architecture and the Built Environment in UK, and has worked closely with the Department of Health on built environment policy development. Her responsibilities include leading the NHS Design Review Program, which is a very, very important aspect. I think we need to maybe induct some of these issues in our systems. Directing research and policy development on community hospitals. Susan has been actively engaged in the 10-year program of investment in healthcare buildings in the UK. At the NHS Confederation, Susan was architectural advisor in a multidisciplinary team. Susan has recently presented papers at international conferences and events in the Netherlands, Germany, Norway, France, Dubai, and India, as well as being a regular presenter at UK conferences. So over to you, Susan. We are eager to hear your experiences.
Thank you very much. Namaste. And I'm greatly honoured to be invited to address this august audience. You've a rich programme with excellent speakers and a grasp of the immediacy of the issues. The inputs have been from different disciplines: medicine, engineering, planning, management. You're all here, and that's as it should be. May I say that my contribution then will be, as an architect, to bring a special look at design. I think yesterday Prem Nath gave a little bit of a trailer to this when he said that he invited you to consider how to make beautiful hospitals. And Farooq Abdullah, in his keynote address on the inaugural session, cautioned doctors not to get so distracted by the toys and the technology that they overlook the patient. That very, very important thing about human contact, putting people at the centre of this process, is all important. And I would like to take that view, to bring that approach to design, approach which is focused on people, patients, visitors, staff, all of them, and to make places, to make beautiful places that perform optimally for the delivery of care, but that are also humanizing. I'm particularly interested in exploring the potential of the design of the environment to make those therapeutic healing places, to make effective, not just efficient workplaces, and to do minimal harm to the planet. In India, I gather that you face a very exciting moment. You face a decade of innovation. Numerous speakers have talked about this. In the UK, we've just had a decade of innovation. And under our current administration, I may say, rather sadly, we face a decade of austerity. And hence the title of my talk, What Lessons Can We Share With You as we face now for ourselves cutbacks in expenditure. We've never had huge sums of money to spend. We've had more capital expenditure in the last 10 years, than we've had for a whole generation. But that's over for us. So how are we going to move forward, having made great changes to our cultural ideas, our concept of what a good design can do in healthcare? It's been a big cultural transition for us, and the question for us, how do we hold on to it, and how can I impart some of those important lessons learned that you may wish to pick up for your decade of investment? In terms of policy, in the past we've had a great emphasis on curative care. The tertiary hospitals at the top of the hierarchy, that's now inverted really. Our great emphasis, our great moving forward must be to look at public and preventative health. It's not quite so glamorous for some of the doctors, but it is very, very necessary for the population at large. We've had a great emphasis on the centralised acute hospitals, and in the last parts of our decade of investment, we've started to look much more at how we can plan locally for wellness. We've had a period prior to this of being driven by service delivery, making things optimally work for staff. Our focus now is on patients. They're our end users. They're the ones we have in mind as the end users. People like you and me who are patients from time to time. We've had a regime in which we've had plenty of regulation and targets and guidelines and standards. We're about to face an administration which says they want none of that. The way that they will bring change in the system is through market forces. The NHS will no longer be a sole provider of healthcare in the UK. In fact, the majority of the budget will go to GPs, who will become commissioners from a variety and diversity of providers. we're shifting from a planned public health service to one which is a diversity of providers driven by market forces. So we're in a great moment of change too. In terms of the environment, this notion of the therapeutic environment, or what it is we need to do, over the last 10 years, we've adopted, in the same way that there is in medicine, the adoption of an evidence-based approach, so there is in the design, planning and designing of the built environment. And that some of that research is around quality. It's about understanding that the built environment can impact on health patient outcomes. We can reduce lengths of stay. We can reduce the drugs that are administered. We can experience fewer complaints. Patients can get better faster and leave our expensive hospitals sooner. But there's also the idea that actually the environment can play a factor in terms of health inequalities. That if we think about the way in which we plan our towns and our cities, we can have an impact on people's public health, their ability to stay healthy, their ability to be responsible for their own health. So in the wider environment, we have a very important role to play as well. And of course, there's quite a lot of work on the value of good design. There is an assumption that it will cost you more to have a well-designed hospital. And I hope that I will be able to show in this talk that that is not the case. It doesn't cost you more. And it has many, many social and environmental benefits over the long term. There's been some talk here about safety, and this is an international issue, both in terms of how the environment can help to alleviate healthcare-acquired infections, not just in hospitals, but outside of hospitals too, and all of those issues about medical errors. This is well-trodden ground, and I'm very pleased to see through the videos that you're very actively engaged in that program here. But there is another issue, and this is something which management is particularly interested in, and that is how to be effective. Can the design of the environment actually help you as an organization to be more productive? And we have a wealth of experience there, whether it's adopting principles from lean thinking, those that have been applied in the car industry, for example, about production processes, or whether it's actually coming from the ground up in the health service themselves. There are people doing plenty of work on this. How can we redesign services? We will have to deliver them with fewer staff at less expense in the future. How can the environment play a role in this? And of course, this very important issue about climate change, which has come up several times in the conference already. So there's plenty of research on that. To go back to that issue of how design can add value, and this is a very significant work that CABE, the organization, one of the organizations that I work for, has done plenty of work on. And it is really to say that the capital outlay on any building is minimal. Let's call it 1. Over the lifetime of that building, you will have maintenance costs for the fabric of the building, let's say 5 times that. It's the running costs of the building that really take up the big portion of money. This is the staffing and the looking after things over a long period of time. So the capital cost, which might always seem so high at the beginning, is minimal. And any design fees associated to that really are very tiny if you see it in this big picture. But the benefits of good design are enormous. We've become much more conscious over the last 10 years in the UK of the role of the health service in and its responsibility towards the planet, towards the wider environment. We know now that hospitals are the biggest emitter of CO2 emissions, bigger than prisons, bigger than art galleries, bigger than offices. But we also know that primary care buildings are far less big in their emissions, but there are huge numbers of them. So one size is not going to fit all in facing this challenge. We will have to have different ways of designing environments in relation to carbon emissions for each of these building types. And we also know from some work that's done by a unit called the NHS Sustainability Development Unit that there's no one single way of solving the issue about emissions. We might have to work at involving renewable energy. We might have to think about refurbishing and replacing buildings. We might have to cut down travel. They're all going to, in their own small way, make a contribution to the massive step change that we need to make in the UK, and certainly that you face if you don't actually take some issues now. There's been quite a lot of talk in some of the presentations about the adoption of renewable technologies, wind energy, solar thermal energy, and photovoltaics. This is an interesting piece of work that we have in the UK, which shows that all of those things can make an impact, can make a contribution, but it's a costly way of going about it. And perhaps a more cost-effective way of going about it is to actually get the shape of the building right in the first place. Its orientation, the density, the shape of the building, and indeed where it is located will have a far greater impact in terms of environmental benefits. And it won't cost you anything. You have to do those things in any case. As part of the cultural shift that we've experienced in the UK, we've spent a lot of time disseminating information. We've had campaigns, we've got things into the press, we've tried to kind of give these ideas out in as many different ways as possible. We've produced guidance, and I don't mean just technical guidance about standards. We've actually produced guidance which is looking at, if you like, the aspirational guidance. Why would you do something differently? How might you change your mindset? How can we make an environment which is greener? How can we plan for people? How can we design particular environments for children and young people in a way that enhances their experience? And CABE has particularly, and my work in CABE has been particularly involved in focusing on creating the dialogue between the informed client and the intelligent designer. There's no doubt about it. Good buildings don't come out of having one or other of these. It is actually those two together and the conversations, the magic happens between them in the conversations that happen. So how can we empower clients to understand what to do? Very often they're caught in a situation where this is the first time they've been asked to be part of a building programme. They don't know what to do. Well, plenty of people have done it, and there are good ways to be able to share that with them. We've also assigned what we've called enablers or experts to work with Healthcare Trust to help them to achieve good buildings, to raise their aspirations, to know what to ask for, and to know when it's being offered. We've instituted a design review panel whose purpose was really to look after, to be a critical friend to those who were developing their hospital buildings. I think we've looked at over 80 projects in the last 10 years at various different stages. Most of them huge hospitals, others of them towards the end of the programme, community hospitals and mental health facilities. It's an opportunity for those trusts who are into their one-off projects to have information brought to them, to share good practice, for the panel to bring an overview from other places, and to help them to see where they could ask for and make improvements in their projects. It's been very well received, though with a little warily at first, but actually once people had got it, came back for more. We've developed some tools. We have BREEAM, which I think is the equivalent of your GRIF, or in the States, the LEED programme. It's really about sustainability and climate change. But we've also developed a tool called ADET, Achieving Excellence Design Evaluation Toolkit, a kind of design quality indicator to help people to measure good design Yes, it can be done, even though it seems like a very subjective idea, the idea of aesthetics. This is very well worked out and has proved to be immensely helpful to people in knowing whether they've got something that they wanted. I'd like now just to go through a series of case studies, just to give you a flavour of what we've done, of how it's changed, and how we're trying to, having, I think, changed a culture in the last 10 years. People now want to have good buildings for healthcare. Let's have a look and see what we've done and how we'll take that forward into our era of austerity. One of the first big major investment projects in the UK was the Norfolk and Norwich Hospital. This was the moving of a city centre hospital to an out-of-town site. And it was on a greenfield site. They had a complete open hand here and were able to arrange the hospital in a very efficient and suitable way, where there was plenty of land, and we haven't always had that issue. And here's another one in Edinburgh. And I would say if there are, and it's a similar situation, moving the hospital out of the city, putting it on the edge. And there have been some unfortunate, perhaps unforeseen consequences in these programs, which is that it's an awful lot of travel time for people and an awful lot of travel arrangements where people could more easily get to things in the centre of town. They now have to travel some distance to get to their hospital. And in terms of how the hospitals themselves are arranged, very typically separating out the hot bits of the hospital, the operating theatres, the diagnostic suites, the things which require a very intensive equipment and technology and very special environments in terms of their temperature control, their air pressures and that kind of thing. That's all scooped together in one place. And the more hotel-like environments, the doctor's offices where consultation takes place, or the inpatient beds, very much like hotel planning, separated out into another part. This has become a general feature of most of our hospital design. Here's another major building, huge building on an existing hospital site. But all of these, I think, and perhaps even this one as well, University College in London, demonstrate this idea of the huge monolithic building, the kind of temple to tertiary care. This one is in the centre of London, so it is vertical rather than just horizontal, but it has those same features and has the separation out of the diagnostics from the other part. As we've gone through the last years of our decade of innovation, we've started to see something which is a bit more like keyhole surgery, adding a little bit here and there, making new additions, not compromising on quality or standards. In fact, for some trusts, setting new standards in terms of their built environment. And here at Great Ormond Street, one can hardly tell what is the hospital and what is any other building on that street, a feature that I particularly like, is a new wing to their hospital. And it deals with the street very well. It deals with those issues about privacy and dignity. You can't see into the hospital rooms, but the hospital looks out onto the street. It is part of everyday life. This is a project called ACAD and then BCAD. It was built in 2 phases. ACAD was our first ambulatory care and diagnostics centre. And it's been a remarkable building in that it was the first really significant time we built a model which had no beds, and it was entirely for ambulatory care. And it was built on the hospital site and was very much set a standard in the UK for design quality. Lots of light, lots of careful use of colour, but a great sense of space. A very welcoming entrance that was easy to find. I yesterday left the auditorium to go to another meeting in this building, and after the meeting was accompanied by my host. But I must say, I had no idea where I was going, and I've never come to Ames and thought I could find the front door. I'm sure Many of you have this experience too. So these issues about how people come to the building, how they find their way into the building, that they are welcomed, they are made to feel welcome by the environment itself, and of course the people who work there. These are very key to allaying the kind of anxieties and fears that people have about coming to have scary, scary interventions, some of which we've seen on the screen earlier today. So after the building of ACAD, which was really for day surgery and day consultations, a sister project was put together with this called BCAD, and that was the rest of the hospital. But they took the opportunity to not rather expand their bed numbers, but rather reduce them. So they were looking at an entire model of care which would be dependent on other services happening outside of their hospital in primary and community settings so that they could make their hospital just as big as it needed to be and no more. And it's a very, very interesting project. I would say it took them 10 or 12 years to develop that model of care. Many of us don't have that long to think about it. And that's not to say that this was a project that was long in development. It was actually the service planning that just took a very long time to get to. It's been replicated in other places now, and I'm sure there are many lessons learned that can be translated to other circumstances. In the same vein, this is another ambulatory care hospital. This is in Scotland, it's in Glasgow, and it's on an existing hospital site. And it has taken that idea of pulling together all of the outpatients, all of the clinic activity, many of the diagnostic activities into somewhere that is very separate from where the beds happen. And the part of the motivation for this was that people's outpatient appointments were being shifted and shifted and shifted as
otherwise also. They can provide OPD services and they can be customized to stay there for a fortnight or a month till other services are restored. Most important are the operational constraints of mobile health units and these relocatable hospitals. We have to do sound planning before we move all these infrastructures to various sites. Training is a very important component, as I mentioned, with the Orbis Hospital. The logistics, form a very important component of planning. Chief supplies and equipments. One must plan adequately from where there will be replenishment of drugs, medical equipments, medical stores, and other disposable and other healthcare delivery items. Water, a very important component. These units, while they are moving, should be self-contained for such time that they are able to establish the safety of the water there. They should carry portable RO plants with them so that the minute they reach there, they can check the water there, ensure the safety, and start utilizing them. The Ministry of Health and Family Welfare, Government of India, has recently planned on these mobile health units with the reverse osmosis plants so that water, which is an important component, is taken care of. Ration, fuel, and communication are other three important things when we are moving into an unknown place. The normal phones and the normal satellite telephones, that's the mobile phones, will not work properly. So what we need are satellite phones. We should have an independent phone system to handle all the casualties. What are the functional requirements of a mobile health unit? The functional requirements are they should be ready to move the minute they learn of an emergency. They should be very well versed with the backup sequence. They should keep their load tables ready in duplicate. By load tables, I mean that they should exactly know which equipment, which store items are there in which all boxes. The signages on the boxes should be very clear, and the team operating that should be aware of what is where and how to move. For this, at least twice a month, mock drills are required. The backup supply chain at various parts of the country or the various parts of the area where these units will give coverage should be pre-planned, documented, and accessibility to those authorities should be clear to those people who are in command and control. The various containers, I'll quickly go through. The various functional units are a ward unit, container, and OT complex. That's the OT module. That's a toilet complex. We can also plan hospital laundry system in that. That's a kitchen container. That's a one-chair dental unit. And this is how the containers are loaded and unloaded. A 7.5 into 10 ton vehicle will be required for transporting all these containers. And 20 such movers will be required for a 50-bedded hospital. I have already stressed on the importance of training. The developments in India, these pioneering organizations, Armed Forces, Medical Services, Ministry of Health and Family Welfare, all these organizations have already adopted this mobile health unit, and they are functioning extremely well in terms of necessity, and they are able to react to a situation faster than anyone else. What are the problems envisaged? Quickly, I'll go over it. The road and infrastructure, that's a problem. We have to plan which is the route to be taken. The land area, what is the availability of water there, where waste will be disposed, all that needs to be pre-planned. We have to take care of the local rules, the communication problem, and the logistic supply chain. To conclude, relocatable hospital may be the solution to the increasing need of healthcare of our country. In any emergency situation, it is the relocatable hospitals or the mobile health units which can take on and provide effective care to all those who need them. And at last, he who has health has hope. And he who has hope has everything. So I'm sure, ladies and gentlemen, we all will go back from this place with a lot of hope to do the best to improve the healthcare scenario of our country. Thank you all.
Going to deal with a variety of problems relating to heart and cardiology and coronary diseases. And in that way, his talk is very, very important, very momentous steps have been taken here in this institute. And in that, he is playing a very vital role in the development of indigenous stents. Stents are extremely costly, and cost factor is one of the very important issues facing the medical health care. So Professor Balaram Bhargav has been at the Indian Institute of Medical Sciences for the last many years. In fact, 20 years.